Good afternoon, everybody. It's my pleasure today to talk to you about obesity and pelvic floor dysfunction. As we all know, the rates of obesity are increasing very rapidly. These are figures from New Zealand that show since 1975, so just 45 years ago, the rates of obesity amongst Europeans have tripled. And even in the last 25 years, the rates amongst our Pacifica women have gone up from around about 50% to 70%. There's almost a normalization of obesity. And if you look at parents of obese children, only half perceive that their children might be overweight. And of our children coming through, 1 in 3 are obese or overweight. And of those, 80% will go on to become obese adults. If we look at obesity rates in Australia, unfortunately, you are equally in trouble. In the 2 to 4 year old age group, about 25% of children are overweight or obese, and that increases to about 60% in those over 65, with men and women women being more obese than men. You've got some real obesity hotspots in Australia. Majority of these are in Queensland, Darling Downs, Ipswich and Mackay and so on. It's a real obesity epidemic. If you look at the graph to the left, it's the number of adults with obesity in millions, and this is in Australia. And in 2004, you had 2.4 people who were classed as obese. This is now up to about 6.8 million now. And if you look to the right of the screen, you'll see that this rate in obesity almost mirrors the rate of fast food consumption and the number of fast food outlets. And this is a slide with figures not to be proud of. Obesity rates internationally. New Zealand is 3rd out of the OECD countries, and Australia is 5th out of all OECD countries in terms of obesity. So how does obesity affect the pelvic floor? I want you to imagine your abdomen is a closed system and the pelvic floor is a flexible base at the bottom of this. And to a certain extent, your ab muscles at the front are also movable. Within that, you've got the contents of your abdomen, which are fixed. And in an obese patient, in addition to the normal intestines and so on, you'll have a large volume of fat. Every time we take a breath or cough or lift, we increase our intra-abdominal pressure. And if you're obese, your starting pressure is going to be higher. So every single breath you take, every lift you make is adding additional stress onto your pelvic floor muscles. So we can measure this by measuring intra-abdominal pressures. And if we go to the middle of the slide here, women with a normal BMI, you'll see have a resting intra-abdominal pressure of about 5 to 7 millimeters of mercury. But if you look at obese and morbidly obese women, that pressure rises almost double. If you then take that lying person and put them at a 45-degree angle, you'll find that there's a 9 millimeter rise on average in the intra-abdominal pressure, bringing that pressure up in the morbidly obese to up to 23 millimeters of mercury. Well, we've also measured the intra-abdominal pressures in women just about to undergo cesarean section, so to term pregnancy, and those pressures are actually lower than the pressures experienced by a morbidly obese patient every single day. And I'm sure those of you who've been pregnant will understand the heaviness and the pressure that you feel at that term. Perhaps I can illustrate this better in this graph. This shows intra-abdominal pressures measured in the blue line, a patient with a normal BMI, and the red line, a patient who's morbidly obese with a BMI of 37. And you'll see that in a patient lying, the intra-abdominal pressure is double that of the patient with the normal BMI. If we then take that same patient and stand them up, the intra-abdominal pressure is again doubled. But look at this, it's 30 millimeters of mercury, whereas our pregnant woman only had a pressure of 22 millimeters of mercury. Take this same patient and take them for a walk down the street, and there's almost a frame shift in pressure change. And with every single step they're taking, they're applying a huge amount of pressure onto their pelvic floor. So we've thought about pressure affecting the pelvic floor, but what other factors with an obese patient might affect their pelvic floor? Well, we might have strain and damage stretching to the pelvic floor muscles. That is also associated with the stretch of the nerves, and we know in obese patients that there are some nerve conduction abnormalities. There are also the obesity-related comorbidities such as diabetes, and this can result in diabetic neuropathy and microvascular disease. We've also got the additional problems of stress and strains on the intervertebral discs, increased risk of things like disc herniation. And then some interesting studies on rats show that the ghrelin levels, ghrelin is something that gives us hunger, and ghrelin levels are higher in obese patients and have been associated with a weakening of connective tissue in rats. We don't know yet, but that also possibly transposes onto humans. Moving more specifically onto different symptoms, obesity and fecal incontinence. Well, it's not something that anybody likes to admit to or talk about, but within our population, as you know, the fecal incontinence rate's up to about 12%, with incontinence of liquid stool being the commonest complaint. There's a number of issues associated with the development of incontinence, such as childbirth injuries to the pelvic floor and anal sphincter, neurological damage, chronic constipation, previous surgeries, and of course, aging and mobility, not being able to get to the toilet on time. The incidence of fecal incontinence increases markedly as we age, but it also increases as our weight increases. And in population-based studies, fecal incontinence is 54% more prevalent in obese compared to normal weight women. In studies carried out on bariatric clinics where patients are waiting for surgery, the incidence of fecal incontinence was up to 32%, with the commonest problem being leakage of liquid stool. The other finding is that women are fighting hard against this incontinence, and obese women actually have a higher anal resting and squeeze pressure than women with a normal BMI. So their anal sphincter is having to work hard to resist the intra-abdominal pressure. But this perhaps gives them less ability to resist an increase in pressure beyond that. Perhaps they're near their physiological limit, and resulting in a lower threshold beyond which they leak. This is just showing the risk factors for fecal incontinence from the nurses study, and you'll see that there's almost a linear relationship between BMI and risk of developing fecal incontinence. So perhaps women who are obese have bigger babies, and perhaps that is resulting in an injury or an increased risk of injury to their anal sphincters. One would think that was the case, but in fact, in large population-based studies, such as the SWEPOT study, they actually found a reduction in third-degree tears and fourth-degree tears with increasing BMI. And the odds ratio for morbidly obese women having a sphincter injury was actually half that of normal weight women. And this is just showing this in more detail, that women with a low BMI actually have a higher risk of anal sphincter injury compared to women with a normal BMI, and women with a high BMI, again, have a lower incidence of obesity compared to those with a normal BMI. So what happens if we lose weight? Does that make a difference? Well, in fact, some studies, such as the PRIDE study, put women, divided them to those having diet and exercise and a group of untreated women. And they found that these women had a mean weight loss of 7.8 kilos. And actually, as they lost weight, their problems with fecal incontinence reduced, and their fecal incontinence scores actually improved by 13% with a relatively small weight loss. So let's move on to obesity and urinary incontinence. Well, you can understand that if you're generating very high pressures, you might be able to overcome the mechanism for leakage prevention with stress incontinence. But there's also a link with obesity and urge incontinence. And there are some explanations for that. We know that women who are obese develop a sort of chronic low-grade inflammation in the bladder, and you can actually measure an increased rate of urinary cytokines with this. Diet-induced obesity, so women who have diabetes, develop an increased amount of macrophages in the adipose tissue surrounding the bladder. And adipocytes, which damage the fat layer around the human bladder, may increase and lead to inflammation and triggering of overactive bladder symptoms. Plus, of course, we get the microvascular damage associated with diabetes. So when we look at other studies looking at the relative risk of urinary incontinence and BMI in epidemiological studies, we can group these together and we find a clear dose-response effect. So for every 5-unit increase in BMI, there's an associated 20 to 70% increase in the risk of urinary incontinence. And if you follow that through, there's a 30 to 60% increase in incidence of urinary incontinence 10 years on for each 5-unit increase in BMI. So let's look at this in a more graphical form. The left-hand side of this graph shows the odds ratio of developing urinary incontinence with increasing BMI, and on the right we can see the severity of the urinary incontinence. So as we become heavier, the incidence of urinary incontinence increases, and the severity of that incontinence increases as well. There's also some other evidence about metabolic syndrome, which is associated with obesity and urinary incontinence. And some of the mechanisms associated with that include oxidative stress and microvascular changes to the pelvic floor, which results in an injury to the detrusor muscle and the urethral sphincter, and there's some resulting involuntary bladder contractions. So there's also been some other studies done by one of my friends, Carven, in Germany, and they did ultrasound studies looking at women with a normal BMI and those with obesity. And what they found was that the bladder neck sat lower and the genital hiatus, so this is relating to the pelvic floor muscles, was wider in those with a higher BMI compared to non-obese controls. So the pelvic floor muscles are having to work against pressure to try and close the urethra, which is in an abnormal position. Well, there is some good news that if you lose weight, you're less likely to to have stress incontinence, and your symptoms are likely to improve. So weight loss is associated with a reduction in intra-abdominal fat, intra-abdominal pressure, it decreases urethral hypermobility, and even a 5% decrease in your weight is associated with an improvement in symptoms, including nocturia as well. So just to highlight that a little bit further, these are patients having a more dramatic weight loss with bariatric surgery. And in Bergio's study, 100 women 12 months post-gastric bypass showed a 44% decrease in urinary incontinence and a 65% decrease in fecal incontinence. And similarly, in another study where the BMI reduced from 46 to 33, there was a 50% of women actually became continent, and of the remainder, 33% had a reduction in incontinence episodes. And this is just showing again in graphical form the percentage of women with resolution of urinary incontinence by the amount of body mass index change they've had. So if you've had a 20% decrease in your BMI, you have a 73% chance of improving your urinary leakage. And again, just another study summarizing all of the studies on obesity and weight loss and urinary incontinence. And to the left of the vertical line, it shows an improvement in urinary scores with weight loss. So this is some outcomes of patients who've had surgery from the British Society of Urogynae database, and women who've undergone midurethral slings. They do show all show an improvement in urinary incontinence following midurethral sling surgery, but the magnitude of that improvement is less as we reach very high BMIs of 45 and beyond. We also see an improvement in overactive bladder symptoms, and these improvements are around about 80% of mixed incontinence in a normal BMI, improving down to only about 55% of mixed incontinence patients with BMIs over 45. Well, is the surgery risky? This is again relating to midurethral slings. Actually, no. What you find is women with a normal BMI are actually at higher risk of bladder perforation than women who are morbidly obese. If we go up to the extremes of obesity, these will be small numbers. When with obese BMIs of 50 and over, the rates come back, but are still below perforation rates of women with a normal BMI. How about de novo overactive bladder symptoms? Well, these do rise with the extremes of BMI. Perhaps this is because tapes need to be significantly looser in patients with higher BMIs than those with a normal BMI. And there's a nuance to this, and I suspect the tapes are putting slightly tight. This is a study from my own department where we have huge rates of obesity. In fact, only 17% of my patients have a normal BMI. And what we found is 60% of our patients with raised BMIs over 35 have mixed urinary continence symptoms, compared to only 37% with a BMI of less than 30. And the outcomes are poorer in the women with morbid obesity compared to those with a BMI of 30. However, we don't ask these women to lose weight. The chance of losing weight with a BMI of over 40 is only 2%, and I think it's actually a cruelty to try and make them lose weight. And we find that severely obese patients are still somewhat or completely satisfied in 70% of cases, compared to 91% of cases in the severely obese, in the non-obese group, beg your pardon. Next, we'll talk about pelvic organ prolapse and obesity. Of course, this is a complex issue. It's related to age, the number of children you've had. You might have severe constipation and strain all the time. Perhaps you've got poor genetics, other comorbidities such as chronic cough or obesity, which all come together to affect your risk of prolapse. But in larger studies, things can be pulled apart a little more easily. And if we look to the Women's Health Initiative study, it looked at gravity and parity, but it also looked at obesity in terms of risk of incontinence, prolapse. And what they found was there was a correlation between BMI and risk of prolapse. So over normal weight women had a 30% chance of prolapse, compared to women with a BMI over 30, 43% chance of prolapse when they were examined. And this didn't matter really whether they had a previous hysterectomy or not. The Swedish population study was another very large study of over 400,000 women. And the bottom line from that was, for each unit rise in BMI, the odds of symptomatic prolapse increased by 3%. So quite a remarkable correlation there. And again, this is, don't worry about the detail. It's just looking at a systematic review. Lines to the right to show that there's a correlation between the risk of BMI rise and prolapse. So is the damage already done? If you're obese and you have prolapse, can you, like you can with stress incontinence or fecal incontinence, lose weight and your symptoms will go away? Or perhaps there's a loss of integrity of the connective tissue and a stretching of the fascial and ligamentous support that's permanent. There's been a number of studies comparing this, And what they unfortunately found was if you increased your weight over time, your risk of pelvic organ prolapse increased. But if you lose weight, in fact, it doesn't affect your prolapse, the prolapse that you already have. And in fact, 10% weight loss, it didn't lead to a regression of the prolapse. And in patients with grade 2 and 3 prolapse, it was associated with a worsening of uterine prolapse. If we look at outcomes of pelvic organ prolapse surgery for women with obesity, surprisingly, the studies are really limited, and most of the studies are being quite obsessed with looking at operation times and relative risk of complications in obese to non-obese women. But what the limited studies that we do have show that there's no association between BMI and surgical outcomes at the 5-year mark. But most of these studies are not using data on women with BMIs of over 35. They're women with BMIs up to 30. Don't worry again about the detail on this, but it's basically a whole list of potential surgical complications comparing women who are obese to non-obese. And there was no significant difference in any complication that you could imagine except for readmission to hospital. And that's possibly related to infective courses. Sorry, I will just go back a second. There was one useful study, the OASIS study, looking at sacral colpopexy and obesity. They followed 300 women for 12 months, and they found no difference in failure rates between normal, overweight, and obese women. So this can help us in our counselling. There was no difference in the symptomatic scores, and there was no difference in the mesh positioning, i.e. the mesh hadn't stretched in the obese women. So in conclusion, BMI does have a strong association with pelvic floor dysfunction. Weight loss is effective in improving symptoms of urinary incontinence, fecal incontinence, but sadly not in symptoms of pelvic organ prolapse. Surgical treatment for stress incontinence is less effective in our population of extreme BMIs, but it still is an effective procedure. And we've got the population, both in Australia and New Zealand, to conduct much needed studies on outcomes in terms of pelvic organ prolapse surgery. And in this talk today, I haven't had time to touch on sexual dysfunction. So thank you from lovely New Zealand. I wish I could have seen you all in person, but hopefully in the near future. Take care and thank you for listening.